one of the important things about medication and psychotherapy is to find the right dose, because the way I was trained, and I was well trained, I'm not complaining about my training, was that the target should be a total eradication of symptoms. And the mantra was treat to remission, treat to remission, always treat to remission. And I still believe that one should treat to remission, but one should achieve a long-lasting result when one gets to remission, and that can't be done with medication. See what I mean?
Can you say more about that?
So the target is still to have the person be free of their symptoms, but the method has to be psychotherapy, because that's where you get the long-lasting changes in the nervous system that cannot be achieved with medication. Medication is a fertilizer or a catalyst for the psychotherapy to occur. That's what it's for. It's short-term, and if you use too high doses or you treat someone for too long with medications, you're actually undermining that process of the full recovery. And I've seen that where a person has been on an SSRI for 10 years, let's say, and then they move to Boulder and they make an appointment with me, and I ask them, have you been in therapy? No, I haven't done any therapy for 10 years. Okay, well, what's your plan for this medication? Well, I was told that I could just take it forever. Well, there are problems, with taking medications long term. And for example, with SSRIs, there is a group of people who are going to develop more problems with their mood in the long run after being on an SSRI for 5 years or 10 years. Some people call that SSRI-induced bipolar disorder. I would just say it's called using the wrong tool for a long-term treatment. So it's a good idea to use short doses, short treatments at low doses whenever possible to minimize side effects. So my goal in working with a psychotherapist is to soften symptoms enough that the person can get out of bed, go to work, participate in family relationships, participate in therapy, make it to appointments on time, not lose their job, but to have symptoms still be available so that psychotherapy can occur. And there's a phenomenon called Prozac apathy that is well known within psychiatric circles, where you give somebody enough Prozac, they stop caring about their problems. Problems don't go away, but they don't have any motivation to change them anymore. So that's not a very good result. That doesn't help people get to where they need to go on their path.
Can you just a moment ago you said a phrase about how you want to medicate to the point where people are functional, but you want to keep symptoms present.
I want everyone to get a long-lasting, permanent healing from their condition. I want full recovery, permanent full-time recovery. And that's why I require people under my care to be in therapy if they're on medication. They have to be in therapy, because medication is a Band-Aid. It's a short-term effect that is helpful. It's very helpful for what it is. But you can't rely on it too long because of longer-term side effects. So I want people to understand that when they come to see me, that it's going to take some effort to overcome serious anxiety, post-traumatic stress symptoms, especially complex PTSD, childhood traumas. But doing the work is so worthwhile, because you can, with trauma, you can overcome it. It's very helpful. It's very exciting. So for example, when I see a person who, let's say, clearly has a bipolar illness, and they their family had a terrible car accident when they were 12, and they were the only survivor. You know, I'm hoping that their bipolar symptoms are going to get better by working on the trauma. You know, because bipolar is understood as a biological condition. It's a problem with brain wiring and brain chemistry that's mostly going to require intensive long-term, lifelong treatment. Maybe not medication, but most people are going to end up on a mood stabilizer for the long haul. Right? So my approach is, okay, let's treat the bipolar and let's address the trauma. And let's see if your bipolar illness symptoms get better, which they usually do, by taking care of the trauma piece. Or let's see if they even go away from dealing with the trauma. And that does happen too. So trauma is a hopeful diagnosis because it's resolvable. It's very doable. Now, people can also manage bipolar illness, certain forms of it, by just attending to their sleep and making sure if they sleep 8 or 10 hours a night, you know, in some cases, they might not need a mood stabilizer. You know, there's fish oil, there's True Hope products, there's all kinds of things that people can do from a natural standpoint for bipolars, but that's not what we're talking about today. But the point is that it doesn't matter what the person's diagnosis is. If they have trauma in their history, it needs to be addressed because it can be addressed, and because addressing it can soften whatever symptoms they have.
Yeah, it seems to me that the talking about bipolar is important simply because it's such a widely used diagnosis.
Right. So there's a lot of confusion and you know, gray area between the diagnosis of PTSD and bipolar, especially complex PTSD. There are probably no specific questions that you can ask that, you know, will nail the diagnosis one way or the other. You know, it's not like a one-shot deal. If I could give you one question that you could ask and it would determine is this person bipolar or post-traumatic stress, I'd tell you, because it would be great to have that. You know, often it's a lot more difficult to tell.
What's the use in being able to make that distinction?
Well, the important thing in the distinction is, first of all, it's probably going to determine the treatment a lot. It's going to determine the prognosis, and it's going to determine something about what the person's view is about themselves, and what they're up against or what they're in for, in terms of the path that they need to go down for recovery. Well, I think that there is true bipolar disorder that does exist. Okay, so I'm not going to sit here and say I think everything is trauma, and some people do say that, or they say, well, 90% of mental illness is trauma. 90% might be true. I know Bob Scare has thrown that figure out before, but I see people who have something else going on. Okay, and so I mean, I focus more on trauma as my field, but I definitely see other conditions out there. Now, as the True Hope story has unfolded, you know, we see that there are people with even euphoric mania, even bipolar 1 mania, who are suffering from nutritional deficits. You give them enough of those micronutrients, their symptoms are stable. So what does that mean? You know, is bipolar 1 a nutritional deficiency? For some people, it seems to be that way. For other people, I don't know. I don't know for sure. So I think one of the reasons why it's been so difficult to nail down, you know, the genetic origins of bipolar, the genetic origins of schizophrenia, you know, even OCD, is that these are complex conditions that are pretty unique for each person. And some of it's nature and some of it's nurture. There's a combination going on for every person. So, I mean, I believe that there are, you know, serious biological conditions out there that exist, but when you take something like bipolar diagnosis and its popularity over the last, you know, say 10 years or so, I just see a lot of people who, when their trauma goes away and their gut is optimized and their exercise is better and their sleep is better, their bipolar symptoms are either gone or minimized. And since medications for bipolar illness by and large have very serious side effects, why not optimize non-medication treatments to lower the risk, right? For example, lithium causes problems with the thyroid commonly. Hypothyroidism is a common outcome from long-term lithium use, and can also cause kidney damage. So if I have a 25-year-old who I'm putting on lithium who might be on lithium for 50 years, wow, I'm going to do everything I can to minimize how much lithium that person has to take, because I'm looking at a long-term, serious risk of medical, problems.